For those who do not know me, my name is Evie and I'm a Stage 2 dual ICM and anesthetic trainee. So today's topic for teaching is acute upper GI bleed. So during this presentation, we're just going to talk about the causes of acute upper GI bleed, how to diagnose it, its pre-endoscopy management. We will also talk about different stratification tools and how they help in identifying high-risk patients that will need an acute intervention. We will also run through the endoscopic findings and the different endoscopic techniques used to treat an acute upper GI bleed. And last, in case that endoscopy fails, what are our options? So we're just going to talk a little bit about balloon tamponade and tips. Acute upper GI bleed is a common medical emergency and it happens about one presentation every 6 minutes. So the most common cause is peptic ulcer disease. The mortality has remained high at about 10%, with several UK audits revealing poor standards of care. So in general, the causes of acute upper GI bleed can be divided into variceal, which is only the 10 to 20%, and non-variceal, which is the most common actually, and it's 80 to 90%. Now, we discussed about the peptic ulcer disease, so other causes of non-variceal bleed include erosions, esophagitis, and mallory-weiss tears. There are some other more rare causes, such as the Gave syndrome, or otherwise known as watermelon syndrome. And yes, then we have the variceal bleed, which accounts for 20% only. So in the light of the high risk of death and the poor standards of care, the British Society of Gastroenterology has created a care bundle that includes actually 6 management domains. These 6 domains include recognition, resuscitation, risk stratification, therapy, referral for endoscopy, and then review, or known as post-endoscopy care. In general, the most important point when we're assessing and treating a bleeding patient with suspected acute upper GI bleed is it indeed an acute upper GI bleed? The second question is the patient that I have in front of me stable or unstable? And then the third one is it variceal or not? These questions will lead in general to different management of patients, so they're really important to keep them in mind and just answer them as we start resuscitating the patient. Now, regarding the recognition, by definition, upper GI bleed, it's supposed to be bleeding proximal to the ligament of Treitz. It has some typical symptoms and atypical symptoms. The most typical symptoms are melena, hematemesis, or coffee ground vomiting. Hematohasia is typically associated with lower GI bleed. However, especially in young patients, that they have very good functional status and they can keep their cardiovascular system up while there is a lot of bleeding. This can happen also with upper GI bleed. However, at the same time, we're expecting that there will be some sort of cardiovascular instability. Of course, it is important also to rule out the mimics of acute upper GI bleed, such as hemoptysis or lower GI bleed, as we already said, that they require a completely different management. Early at this point, we should consider the likely source of bleeding based on the history and the examination. Stigmata of chronic liver disease, such as spider nevi, pulmonary erythema, jaundice, encephalopathy, ascites, or history of chronic viral hepatitis, they might indicate a variceal bleed, which is important to recognize. If, for example, the patient is already in ICU, on multi-organ failure, on a lot of vasopressors, we should consider about stress alteration. Other important points from the history that can lead us, give us some clues regarding the cause of bleeding, are if the patient mentioned any protracted retching, any alcoholic binge, or had emesis beforehand, we would consider about a mallory-weiss tear. Weight loss, anorexia, dysphagia could show towards a malignancy. Abdominal pain, regular use of NSAIDs, heartburn, smoking, and infection by H. pylori, they would make us consider peptic ulcer disease. Another thing that I found interesting is that in patients that they had a previous aortic aneurysm repair, and they have an infected graft or they're fistulating disease, we should consider that there might be also an aortoenteric fistula. So that's important to keep it, like in the surgical history. Next step is resuscitation following an ABC approach. Patients should be carefully monitored, and resuscitation goals are correcting hypovolemia to bring that blood pressure up and restore tissue perfusion, especially those kidneys, and prevent multi-organ failure from poor perfusion. So from the guidelines that I mentioned, they're saying that an initial 500 ml bolus of crystalloid should be given, and blood should be sent for full blood count, USANEs, LFTs, coagulation, group and save, and then depending on how severe the bleed is, we might need to cross-match some plots. Vasoactive agents should be started only in patients who keep being unstable hemodynamically, or they do not respond to resuscitation. So in general, there are no RTCs that they tell us that one vasopressor is better than the other. However, it is said that we should avoid dopamine because it has a higher risk of arrhythmias, and especially in the critically ill patients. Noradrenaline is a very good option. It's probably the first line vasopressor used in these situations. And regarding vasopressin, although we use terlipressin in upper GI bleeds that have to do with varices, it should be an add-on vasopressor rather than a first line. And this is because it can cause gut ischemia. Yeah. Right. So regarding transfusion, it should be, we should be very careful about it. So goals for transfusion or triggers would be an HB of less than 70, unless we have to do with patients with cardiac disease or ischemic heart disease. Platelets should only be transfused to patients that they're actively bleeding and they have numbers of less than 50. In cases of an ongoing hemodynamic instability, despite adequate resuscitation efforts, then we should consider about activating the major hemorrhage protocol quite early. There is indirect evidence from the trauma population that we need to be strict, like again, and go with 1:1:1 ratio of products. Interpretation of coagulation studies can be sometimes difficult, especially in liver patients, if they have like pre-existing coagulopathy. So TEG studies are very, very helpful in this situation, that they can help us guide coagulation. And in cases that we don't have the TEG, at least the guidelines from the gastroenterologist, they say that we should give FFP if fibrinogen is less than 1 gram per liter, or PTT and APTT like more than 1.5 times the normal range. In case of resuscitation during acute or suspected variceal bleed, we should also administer antibiotics and terlipressin. We shouldn't forget that sepsis is a common precipitating factor of bleeds in patients that they have varices. So we should definitely give them according to local guidelines, and then waiting for the cultures from the ascitic fluid. So we just have to make sure that there is a tap done and send for cultures if patient presents and has ascites as well. Now, regarding terlipressin, it is a synthetic analog of vasopressin. It has a slow sustaining release, and this gives us the opportunity to give it via intermittent injections. It's 2 milligram IV, either 4 or every 6 hours. Of course, it doesn't come with no risks and stuff. So in general, we should avoid it in patients that they have ischemic heart disease, they had previous strokes, coronary disease, all this. And in these cases, we could, for example, use somatostatin, which has been shown that it has the same efficiency with terlipressin. However, the only negative I would say for somatostatin is that you have to give it as a bolus and then give it as an infusion rather than like the 4 or 6 times regime of terlipressin. Now, from the critical care point of view, securing the airway to prevent aspiration in an obtunded patient should be considered. In theory, intubation optimizes the oxygenation in the light of increased systemic oxygen utilization to these patients that they're just trying to breathe really fast to correct their metabolic acidosis. However, there have been studies that have shown an increased risk of cardiopulmonary events, and especially pneumonia, increased risk of death and length of stay in patients that they have been prophylactically intubated prior to endoscopy. So probably an aggressive type of resuscitation would be the best thing to do, because it might negate the need for intubation or just even make it more safe. If intubation is decided, then we should take all the precautions regarding a difficult airway, and we should have always some help, a senior consultant or someone in ICU. Regarding the choice of induction agent, well, this plays actually less of a role in experienced hands. What is important is to just reduce the dose and give boluses of vasopressors to improve post-induction mean arterial pressure. At this point, we will also probably review the medication and just see what we continue and what we stop. So in general, there is particular emphasis in continuing low-dose aspirin in acute upper GI bleed. So yeah, maybe it's a lot of details for us, but I just liked it. And you can see on the right side that they had patients with peptic ulcers, that they had an acute upper GI bleed. And what they did is they had a placebo group, and then they had a group that they continued the low dose aspirin, and they measured all-cause mortality rates in 30 days. So we can see on the top right of the screen. And then they also calculated the mortality rates that they were attributable to cardiovascular, cerebrovascular, or GI complications. So this is the lower right side of the screen. So as we can see on the top, placebo group 12.9% all-cause mortality, while the one that got the aspirin only 1.3%. Yeah, and the same counts for the specifics of mortality from cardiovascular causes. Now, at the same time, with the assessment and resuscitation of the patient, we should risk stratify them and just plan for further management. Does this patient need an acute intervention? There are several risk stratification tools, and they are available, and they aim to objectively quantify the risk of death or intervention, early involvement of critical care teams, and discharge of low-risk teams. So amongst them, the Blatchford score is the optimal pre-endoscopy score. As seen on the table on the left, it is calculated by measuring the blood pressure, the heart rate, the HP, blood urea, and also some other factors that we can get from the history. The score ranges from 0 to 23, and any patient with a score of 0 and 1, in theory, could just go home, if we see it from the A&E point of view. Yeah, everything which is above 1, they should be hospitalized. So any risk marker, if present, of course, increases the likelihood of a bad outcome, transfusion, endoscopy, or surgery. So from just going a little bit around the literature, if the GBS score is more than 8, the patients are most probably will need to come to ITU. Yes?
Because it'd be hard to score 0, I suppose, with your blood urea.
Pardon?
You could have a blood urea of less than
It's normal.
6.5.
It's normal.
That would be 2 though, if it's over 6.5, which is still normal.
Well, this is how it wouldn't get any point.
Yeah.
There would be no point.
Where wouldn't it go? Less than 13. Okay, so you've got to have a HB of over 130. Yeah.
Yeah.
You do well to be most anyone to find that over 0.
Okay, so of course, like we said, that these patients are most possibly going cont'd, but again, that's actually a model thing if you see it like on the right side, yeah. So there are no, in general, formal guidelines. The decision making is should take into account the acuity and the severity of the bleed, the risk of rebleeding, and patient comorbidities, yeah. Going next to the risk stratification score, another one is the REFERRAL score. So this one exists actually in two forms. There is one that we do pre-endoscopy, and then we have the complete one, which is calculated after we have the endoscopic findings as well. So the pre-endoscopy one, it is based on age, evidence of shock, patient comorbidities. But in general, it shows moderate prediction of death of high-risk patients. So in general, the most important points that we can get from the endoscopy that make the post-endoscopy REFERRAL score really high, let's say, so you have a high-risk patient, would be if they had malignancy and major stigmata of recent hemorrhage, okay? So to put it into a clinical context, if we take the example of an 80-year-old patient who, according to the medics, has no other comorbidities, and they just came with shock and they had the endoscopy, and then there was an ulcer and it had some signs of recent hemorrhage. So actually, this patient already has a score of 6, which means that he has a mortality. I'm sorry, the red line is on the wrong spot. That's my bad. So this patient has a risk of rebleeding of 32.9% and death of 20% almost, okay? So it's quite high. And this is for a patient who is otherwise, well, slightly on the elderly side, yeah. Moving on to endoscopy timing, trials are conflicting and retrospective. So we know that stable patients will come to harm if they undergo an endoscopy after the 24 hours from bleed presentation. And also we know that there is no survival benefit, at least with evidence, if endoscopy happens very, very early. So what we mean very, very early is like in the first hours and definitely, like before the 12 hours. So things get a little bit more complicated when it comes to patients with ongoing hemodynamic instability, or for example, those that they have a contraindication in stopping their anticoagulation. And to make it more complicated, different societies have also produced different guidelines. So it's interesting that the European Society of Gastroenterology, they recommend actually very early endoscopy in patients that they have, for example, contraindications to stopping their anticoagulation, although that are limited actually. In suspected acute variceal bleeding, both the European and the American guidelines suggest that the endoscopy should happen definitely before the 12 hours. On the other hand, the British guidelines, so the British Society of Gastroenterology, they say that we aim for endoscopy within 24 hours for all, but the most unstable patients, okay? So the ones that they're like hemodynamically unstable, all right? So they don't say anything about patients that they can't stop actually their anticoagulation. So patients that they're unstable, they should be first resuscitated, be stabilized as much as we can, and then proceed with the endoscopy. And it should happen around, let's say, like the 12 hours, okay? Now, so we're having, the next step now is like treatment and endoscopy, yeah? So the patient is having the endoscopy, and what do we see? We can see a nice ulcer. So peptic ulcers can be classified according to their anatomical locations. For example, they can be gastric or they can be duodenal. However, the most common classification, and especially it's the one which is used by the endoscopist, and this is the way for them to communicate with us in ITU, is the Forest classification. Ulcers that they have no high-risk stigmata, defined as ulcers with clean base or hematine-covered flat spots, as we can see them on the right side of the screen. We can see that there are two photos at the top right that they're marked with a green thing, yeah. So they will heal themselves, and actually they require no intervention at all, yeah. If, on the other hand, there is a presence of an adherent clots, a visible vessel, oozing or spurting hemorrhage, this is suggestive of high risk of rebleed, and these are the ulcers that they have to be managed via a dual modality therapy. Okay, so this involves the injection of adrenaline via a needle, followed by electrocautery or clips. So in case there is failure, then the options are to use hemostatic powders, angioembolization, or surgery. The endoscopic management of variceal bleeding in general hasn't changed a lot in the last 7 years. And again, as for the ulcer, it depends on the type of varices present on endoscopy. In general, not all cirrhotic patients have varices, but the higher the child's POO score is, the higher the risk of the patients having actually varices. Variceal bleed happens when portal hypertension, so the pressure sorry in the portal vein exceeds 12 millimeters of mercury, and when it happens in half of these cases, there is spontaneous hemostasis after initial pharmacological management, okay, and stabilization. Mortality is generally high, and half of the cases will require some sort of intervention. Now, varices, as we said, they can be classified into 3 categories. First, esophageal varices, then we have the gastroesophageal varices and isolated gastric varices. So regarding the first, the esophageal varices can be subdivided into 3 grades and 2 grades, and this depends actually, in 3 grades, and it depends actually on their size and how much big they are, how much of the lumen of the esophagus they occupy. So we have grade 1. We can see on the top, on the there's a panel of 4 photos. On the left side, we have the normal one. I'm sorry if you can't see them very well, like I did my best. So you have grade 1, which are small and straight. We have grade 2 and 3, which are like really, really large, and they can occupy more than 1/3, like of the lumen. Yeah. If we go to gastroesophageal varices, so they are classified as type 1 and type 2. So type 1, it is the commonest one, but has low bleeding rates. And these ones arise from the lesser curvature of the stomach, and they extend beyond the gastroesophageal junction. And we have type 2, that they are mainly on the gastric fundus and then go up to the esophagus. In isolated gastric varices, again, they are divided in type 1 and type 2. Type 1, they're found in the cardia of the stomach, and together with type 2 gastroesophageal varices are responsible for 70% actually of variceal bleeding. Type 2 IGVs are really rare, and they're located in the antrum of the stomach. There are also some ectopic varices that they could be on the duodenum, but I'm not going to be bothered with them. Bond ligation is the first modality used to treat esophageal varices, and it involves the placement of an elastic band that will work by capturing the virus, and then it applies some pressure, and then there is no blood flow, so then there is a clot, so then that's it, there is no blood going there. So when this happens, the tissue then becomes necrotic and sloughs off in a few weeks. Now, the gastric variceal bleeding, the management is a little bit like different. So in these situations, the endoscopies, they use glue embolization and injection of thrombin. In those cases of active, massive, uncontrollable bleeding, the options are either balloon tamponade, TIPS procedure, or surgery. Priority in general is ongoing resuscitation, and balloon tamponade is the first line measure if there is a failed endoscopy. Second line rescue therapy is either salvage TIPS, or in case TIPS is not feasible or patient is well compensated, they can have a shunt surgery. Okay, we will speak for both the balloon tamponade and the TIPS a little bit later. Like the TIPS is actually like a shunt sort of procedure, okay, just to offload the pressures and the blood flow from the liver. Okay, so what does it stand for? It stands for transjugular intrahepatic portosystemic stent shunt, and has a role in the management not only of portal hypertension, but it's included. It involves interventional radiology or hepatologists placing actually a stent into the liver by inserting a wire through the jugular vein in the neck, and then threading it and guiding it using the X-rays through the liver. So the stent creates a pathway between the portal vein, which is high pressure at that point, and the hepatic vein, which is low pressure, and releases the pressure of blood flowing through the cirrhotic liver and reduces actually the back pressure. Technical success is defined as a decrease in the portal pressure 20% from the baseline, or to less than 12 millimeters of mercury. While clinical success, it's a little bit of a different issue. So this is either the cessation of the bleeding, or in cases it's used for other situations, is a reduction of ascites, of hydrothorax, and the improvement of liver and renal function. Of course, TIPS is not without any risks. There are some early complications and late complications. So early complications include bleeding, infection, heart failure, liver failure, kidney failure in general, like all multi-organ failure situation. And also it can happen immediately during the procedure and have damage to the blood vessels or the bile ducts. But it occurs like in less than 5% of patients. Late complications of TIPS, this is something that happens quite often. So hepatic encephalopathy affects 1/3 of the patient. That is when you shunt the blood from the liver, then all the toxic products, they don't go to the liver anymore. So they accumulate to the brain, and then they become encephalopathic. Yeah. In most cases, hepatic encephalopathy responds positively to simple measures and medical therapy, but in case it presents after TIPS, then it might just be necessary actually to block off the TIPS. Regarding the patient selection criteria, we saw that TIPS has a lot of side effects and things. So good patient selection is something really, really important. So at least for the elective cases, elective TIPS is not recommended in patients with severe LV function or pulmonary hypertension, as most probably it will lead to heart failure after the operation. And again, this has to do with the fact that you're just shunting blood, a lot of blood, and if there's a failing heart, you just, like flood it with the blood and everything, it's going to definitely fail. That's for sure. However, when we're talking about the acute settings, and echoes, they're not supposed to be very, very accurate. So we should not delay an emergency and potentially life-saving TIPS insertion, yeah, unless we have only like old echoes, not new ones. Now, other contraindications include the elderly patients, or anyway, patients above 65, let's not call them elderly. If they have like severe kidney disease, if they're like high-risk patients to develop encephalopathy, and these are patients that they have Child-Pugh scores of like more than 10, and patients that they are really, really frail and they don't and are sarcopenic. I'm not going to talk about the child poo score. I suspect that everyone knows it and everyone remembers it. Fine, good. So let's proceed then with our other type of intervention that we could do in refractory variceal bleeding. Okay, so this is balloon tamponade. It's highly effective, controls the acute bleeding in up to 90% of the patients, although 50% of them will bleed after the balloon is deflated. So it's in general just a temporizing rescue measure and shouldn't stay for long. So the traditional Sengstaken Blakemore tube is like a sophisticated, actually, urinary catheter, which has 3 lumens. And inflation of the balloon in the stomach, it just applies, pressures, and it controls the bleeding. So there are the Sengstaken Blakemore was like, yeah, it's a 3-lumen tube. However, nowadays there are more modern models. So we have the Minnesota tube, which has actually 4 lumens. So on top of the gastric balloon and the esophageal balloon and the gastric aspiration port, the Minnesota tube has also an esophageal balloon, but we don't really use it, to be honest. Another type of tube which is used for balloon tamponade is the Linton-Douglas tube. So it's just 1 lumen. So it goes into the stomach, it has a balloon, and it just tamponades there. Yeah. Indications for the insertion of Sengstaken Blakemore tube are life-threatening upper GI bleeding of variceal origin or an autoenteric fistula. And we should always remember that it's a temporizing measure. So we should always have a plan from endoscopies. We should know what we were doing, like what will happen afterwards, and we should never, like deflate the balloons unless we're really close to the endoscopy, because they just might start bleeding again. Contraindications include known esophageal strictures and recent esophageal or gastric surgery. Both of these just predispose the patients into esophageal rupture. However, in this situation, like if we have a patient who had a gastric surgery and stuff, but he's bleeding in front of us, again, it's a risk to benefit like balance, and we should think that it's an emergency life-saving measure, so probably we should insert it. Now, the technicalities of the insertion, so it can be inserted either nasally if patients are awake, or orally. Usually it happens like after patients are intubated. So the tubes themselves, they should be kept in the fridge where they are a little bit, like more stiff, and it's easier for the endoscopists to insert them. The depth of insertion, it should be predetermined, and this we know it either by just measuring, like do it from the nose and then just going back to the stomach like this, or just from the endoscopy report, to be honest. It should say where the gastroesophageal junction is. So the tube is then inserted with the patient's supine at 45 degrees. The gastric port is aspirated to just remove any blood which is there, and then it is clamped, and then the gastric balloon is inflated. We then leave the esophageal balloon alone. We don't do anything, and we leave the esophageal port into open drain in order to see if there is any more, like blood coming, if the bleeding is continuing. Actually, that's why we do it. We apply traction, as we can see on the photo, which increase the pressure applied to the cardia of the stomach. And this pressure is applied by a pulley system using 500 ml of saline, a drip stand, and a white ribbon. X-ray, we should X-ray them afterwards to see if it is in good position or not. Left, good. Right, we don't like that. So we can see that the balloon is actually in the esophagus. Yeah. Regarding complications, we can have like minor complications, which occur actually due to the pressure effects from the tube around the mouth or the nose. Severe complications due to pressure effects on the esophagus, the stomach, range from superficial ulceration due to ischemia and necrosis. We can have perforation, which can be primary, either by excessive pressure into the balloon or from the necrosis afterwards. Of course, we can have also the inadvertent extubation from just, like the traction we apply there. If all this happens and still the patient is bleeding and they have, like the balloon and the bleeding has not stopped, then what we could do, apart from continuing resuscitation and asking for help, would be to increase the traction. So to go to 1 liter of the bag, like being there. And we could also inflate the esophageal balloon, but we should aspirate every 3 hours to check, like if there is ongoing bleeding, and also to deflate it completely, the esophageal balloon, every 6 hours for 5 to 10 minutes. And we shouldn't, in general, keep it more than 24 hours, all right? Regarding the removal, they are removed usually before definite endoscopic treatment. If hemostasis is not achieved, maybe we should just keep them a little bit longer, like 2-3 days. If the patients need NG, I would ask actually the gastros to just do it under endoscopy. And after the tube is removed, then I would just monitor for any signs of ischemia, necrosis, of perforation. That could be like other non-specific symptoms like tachypnea, tachycardia, hypertension, or others like the patient has pain when they're swallowing, or they might just have developed pneumothoraxis, pneumomediastinum, and surgical emphysema if there is rupture afterwards of the esophagus. Yeah. The last domain now of the bundle is the post-endoscopy plan. The endoscopy report, it provides an overview of each procedure. So for the acute non-variceal bleed, it should be what they would say. This should explain what they found, if there were any hemorrhagic stigmata, what therapies were administered, how certain the endoscopies are that they have stopped the bleeding, if they had any complications, and the management afterwards. Okay, so on ICU, for example. If for ulcers requiring endoscopic therapy, the patients should start on IV PPIs for 72 hours. So this can be either by an infusion or an intermittent, actually intravenous, like intermittent, like every 6 hours. It's exactly the same, to be honest. If we're talking about variceal bleed, so continue antibiotics, continue vasopressors, start a non-selective beta blocker if blood pressure allows, which is probably not the case for our ICU patients, and then continue organ supports. So reaching the end of the presentation, the take-home message is that in acute upper GI bleed, mortality is high. We should distinguish early between variceal and non-variceal bleeds. The management of the severe upper GI bleed requires a multidisciplinary collaboration, prompt recognition and resuscitation, careful use of blood products, early correction of coagulopathy, and early endoscopic or radiological intervention. And that's it. Thank you. Any questions? Hope not. I know it's a little bit boring. It has a lot of medical parts, but it is like in the exams, all the classification and things like this. I know it's a bit dry.
No, it's good. Help me do this.
When you start considering treating the patients after an upper GI
Consider? Feeding the patient. So if they are on vasopressors, high doses, I don't think that you should start feeding them. I mean, you just follow the normal guidelines that we have, okay? So you wouldn't start it immediately. So that's one. After they become stable cardiovascularly, you should consider it, I think. But again, I'm not like an expert. I can tell you just from the guidelines that I'm aware, the general nutritional, like the Aspen and the Aspen guidelines. I don't know if, Matt, do you have something else to
The guys at Royal, mate.
Yeah. Can we pass the questions to you? Ravi?
Thank you for that excellent presentation. Upper GI bleed is not boring. It can't get any more exciting. If you are involved in the cardiac arrest and someone has had an upper GI bleed, it is very exciting.
So, Ravi, we have one of the trainees here, and they're asking regarding feeding plans, when we would start feeding these patients?
Well, as long as the Sengstaken blackmore tube is there, they can't obviously feed the patient. But obviously, once that's removed and the varices are banded, I think after 3 to 4 days, they should be okay to start the feed. This whole issue around traction with the Sengstaken tubes, I think previously we used to apply the traction, as you said, with I think liter bags and all. There's a lot of problems with those tractions with these tubes because they cause awful ulcers at the angle of the mouth. So nowadays the practice is just to tape them, just like we do our endotracheal tubes. We don't do the traction as religiously as we used to do in the past. Oh. That's practice change that I've seen.
Ravi, are you still speaking?
No.
Ah, fine. we just switched you onto a different speaker because we couldn't hear you, but you then went silent, so we didn't know what had gone on.
Any questions? No questions from here.
No, there's no questions here, Ravi.
Yes.
I can't hear. Yeah.
Well, it depends on what's the cause of the bleed. So the question is role of proton pump inhibitors in variceal bleeding.
Sorry, the role of proton pump inhibitors in variceal bleeding.
Yeah.
So from what I could see, at least from the guidelines that I read, the British Gastroenterology Society guidelines, they don't advise for using PPI in variceal bleed unless there is an ulcer somewhere, a bleeding ulcer.
Yeah, absolutely. It's only indicated in non-variceal bleeds. Any other questions?
Don't give IV PPI until after the.
If there is an ulcer, and not only if there was an ulcer, if there is a bleeding ulcer, because remember when we said about the forced classification, in the first, like in the categories that there were nothing, like a flat, like ulcer, nothing, they actually will not do anything, the endoscopy. So if they don't do anything, you don't even have to give them IV PPI. Only when they have done some sort of intervention for the ulcer, then you should start them on IV PPI. Yeah.
Although routine practice would often be to start a PPI whilst awaiting any definitive treatment.
So I think.
Well, sometimes though they say that it's even worse to do that because it might hide actually the bleeding. So it's a little bit of a tricky situation.
Yeah, you're right. I'd heard exactly the same bit. I think pragmatically most of us actually give PPIs pre-endoscopy, but it does upset the endoscopist because they then, you're right, they then may mask what bleeding there was there.
They need to do it more quickly.
To be honest, like regarding the quickened stuff, I mean, it's actually a point of friction, I think, many times, right, between ITU and endoscopies and when things will happen. I think that my impression, at least, is, without being an expert or anything, all the guidelines that they're saying, like, okay, yeah, just do it at 12 hours, they're actually based on mainly on patients that they were resuscitated. But in order actually to do a good resuscitation to a ward, yeah, it will probably take you 6 to 12 hours. But is that true for ITU? Because I really think that you can do things faster, and as long as you have like your patient stabilized and stuff, like I don't find any reason why it should happen less than 12 hours. But again,
depends on the severity. You've got some minor GI bleeding. The chances in ICU is either a gastritic picture or it's some stress ulceration. Therefore, PPI would be the treatment course, with or without an endoscopy. And if it settles without the need for endoscopy, you could always avoid the endoscopy potentially, and endoscopy at your leisure in the future to look out for something if needed or it recurs. But I don't know, it's difficult, isn't it? And again, you say this is designed around ward patients primarily, rather than those that you tend to see.
And Evie, the other point is blood transfusion in these patients with upper GI bleeds. I think like any other ICU patient, we just sort of aim for hemoglobin of 70 to 80. That's absolutely fine. Over enthusiastic blood transfusion tends to increase portal pressure and worse bleeding.
Yeah, correct.
We're going to be very cross if we do that.
True. Yeah.
Any questions else from you guys? No more questions here, Ravi.
No, not here as well.
Thank you.
Thank you.
Thanks.